Welcome to Body in Balance Podcast. I am your host, Charlotte Johnson, the certified licensed physician assistant, sent here to kick some knowledge your way once a week for the purpose of educating, informing, and enlightening this audience concerning physical, spiritual, and emotional aspects of our bodies in relation to our Creator, the one, the only, the true and living God. He is the King of Kings and the Lord of Lords. Let us give it up for Yahweh. Hey, good people. I am so excited about this episode today. We're going to be talking about conductive hearing loss, understanding the hearing loss, and diagnosing and managing it. Now, with talking about the conductive hearing loss, let me get some things together here. Get my banner straight. And I'm going to be looking for a engineer to be a part of the team. Let me tell you something. Body and Balance is growing so well, and I want to thank you all of my listeners, for subscribing, telling others, and joining and coming to the YouTube channel. We're also on Church Family Channel, the Church Family Channel, which is sponsored and owned by Brother Steve. And another thing that I want to talk about is, let's see, it's going to be July the 7th through the 11th. I'm a part of the Church of God in Christ. I've been with the Sunday school department for years. Oh man, like way back, like 8 tracks. And so I have been a part of the Church of God in Christ International Sunday School Department for a long time. Every year we go to an AIM convention, which has been going on since 1997. And so we're going to be in Phoenix, Arizona. So if you follow me and you know, and you're a part of, because I do hit up a lot of the Kojic websites, Facebook pages, Instagrams, and the like. I haven't gotten on TikTok. If anybody wants to join me on Body and Balance and help me to get on TikTok and do some things, I'd greatly appreciate it. But you're going to see the pop-up banner for Body in Balance. You're going to see the pop-up banner for Body in Balance right there at registration desk at the AIM Convention 2025. We have been blessed to be a sponsor. Yes, we've been blessed to be a sponsor for that convention, one of the major conventions of the Church of God in Christ. It's the youth convention. It's the missions convention. It's Sunday school. It's music. It's live. It's evangelism. It's going to be popping. And if anybody's anybody, you need to be there and be part of that somebody. Yes, we look forward to seeing you. Look for my pop-up banner. Got a QR code, and you'll be able to scan that on your phone, and you can start watching the information that I give out. Now, we're talking about conductive hearing loss, and that's one of 3 types of hearing loss. So this is the first type of hearing loss. We talked about the anatomy of the ear so you could get an understanding that there were 3 separate parts. There's the outer ear, middle ear, and then there's the inner ear. The outer ear the middle ear, and then there's the inner ear. This particular disorder, conductive hearing loss, affects the outer ear or the middle ear. Something would be going on in the outer ear or the middle ear to give you conductive hearing loss. We're going to talk about types of hearing tests and understanding those tests, and what a provider, an otolaryngology PA, an otolaryngology nurse practitioner, or an otolaryngologist would be looking at when they read those. We read, I'm going to say it again, I'm going to keep saying it throughout this series, that otolaryngology providers read EKG, read audiograms like we read EKGs, like a cardiologist reads an EKG. It is very vital to our diagnostic practice. We need to have an audiogram. You may not think that you have hearing loss. You may not think that anything's going on, but we utilize those tools as part of our diagnostic training to find out what's going on with you. So we need that. I am procuring an audiologist to come on board, and I think I'll put together a slide, because I don't want my audience to not know when we're going to pop on and be live. I've got some exciting guests. I can't tell you the dates yet because we haven't nailed those down, but we're going to be having an audiologist to come on and explain how you do children testing, hearing testing. We'll talk about how you do hearing test, the importance of the hearing test, what they need from you, what they're looking for, how they adjust hearing aids. What do they do? Because when you come in to an audiologist office, they do the testing and they do the equipment, the hearing device equipment. So we're going to talk about different types of hearing devices. But when you come to me, I couldn't tell you what to do with your hearing aid or how to clean it and that kind of thing. That's just not what we usually do. That is done by the audiologist. All right. That being said, let's move on. There's quite a bit of information. I've run into some time with a lot of our announcements, but I'm just so excited about what's going on. And we are topping the listening charts. I'm so glad that you are on board. So here we go. What's our agenda for today? Well, I'm glad you asked me. We're going to be talking about the introduction to conductive hearing loss. We're also going to be talking about diagnostics and symptoms, or the diagnosis and symptoms of some conductive hearing loss. We're going to be talking about causes of hearing loss. What are some of the causes of hearing loss? What's going to be the cause of you not hearing well? And then we've got treatments. I was in the military. I served in the United States Army for 8.5 years. And I not only saw a problem, picked out a problem, but when I presented it to my sergeants and my leaders and the captain, I always made sure that I had a solution. So we're going to give you some solutions for your problem if you have conductive hearing loss. It's only if you have conductive hearing loss are you going to need that. So in this introduction, well, you first got the outer ear. So you see there, that first picture is the outer ear. The outer ear. That's called the auricle. That is the auricle. The flap that's stuck on the side of your head is called the auricle, the ear. Now that ear, that's not the organ. That's not the real sense organ. The flap that's stuck on the side of the head that you can see, that's not the actual sense organ. What that is a part of the sense organ. It helps to funnel sound waves down that canal. where it says ear canal on that middle picture. Let's jump over to the middle picture. So you got the outer ear, which incorporates, it's called the auricle or outer ear. And then there's a small little part that is called the pinnacle. The little piece of cartilage in the front of where that hole is called the tragus. The tragus. And then where you put your earrings in, that's the pinna or the earlobe. The earlobe. Now, where you stick your finger in, and God forbid you're sticking Q-tips in there, but in that tunnel where there's wax, that's called the ear canal. If you get enough wax in there and it is hardened, it can cause conductive hearing loss. We're going to have a section or a session where you see ear cleanings, and we discuss how to clean an ear, and you'll be able to watch that ooey gooey stuff coming out of the ear. It's really cool. I enjoy it when I have to do that. But that will block up the sound wave from hitting the eardrum. So if it blocks it up or slows the sound wave down, the vibration down, when it hits the eardrum and then starts to stimulate, let's look at the third picture, those three little yellow bones or those tan looking bones. The first one that is attached to the eardrum is called the malleus. The malleus. The middle one is called the incus. The incus. And the third one that looks like, they call it we used to call it in the 5th grade an anvil, but that's the stapes. The stapes. It has that little flat pad and it looks like a wishbone at the end. That is called the stapes, and it is the last bone that is connected to and touching the cochlea. So that's connecting the middle ear to the inner ear. Remember, we talked about vibrations, sound vibrations. They go through the tunnel, hit the eardrum that's like a tambourine, and it shakes those three bones. That shaking stimulates the cochlea or the inner ear, where there's thousands and thousands of nerves and fluid that's in there that transfers mechanical energy to electrical energy. So that vibratory mechanical energy gets transferred into electrical energy, which goes through a nerve called the acoustic nerve. And there's also a vestibular nerve there. We talked about that during the vertigo sessions. Okay. Now, I told you there are 3 types. There are 3 types of hearing loss. So the type of hearing loss that we're going to be talking about today is conductive hearing loss. Conductive hearing loss. Because we have 3 different types of hearing loss, we're going to spend great time on each one. I'm going to actually spend great time on 2 of them because the third one is a mixture of the 2, both conductive and sensory neural. And we'll talk about the conductive today. Conductive hearing loss, the definition of it is loss when occurs when the sound waves cannot effectively pass through the outer ear, as I showed you before, to hit the eardrum. This type may be caused by ear infections. So if you get fluid in the middle ear and it gets infected, it becomes very thick. That means the vibratory movements of those bones is slowed down. So fluid in the middle ear, an infection in the ear. You could get an infection because, God forbid, you're taking rat tooth combs, bobby pins, pens, pencils, those long Edward Scissorhands fingernails that we put on, that ladies like to put on, and scratch down in your ear canal, tear the skin. When you break the skin, now you can open the door to infection, because we all have staph, strep, and fungus on our skin. No matter how clean you are or how dirty you are, you have that on your skin. It's part of your body's normal flora. But when it gets out of hand, that's how you can get infections, which makes your ear canal, let me go back to that picture, makes your ear canal swell up. And when it swells, if it swells shut, then that's an infection, and it's called an outer ear infection, otitis externa. Otitis externa. It is also called swimmer's ear. Listen, you don't have to swim to get swimmer's ear. You can get swimmer's ear from doing the things I just got through telling you not to do, using bobby pins, the end of a pencil, the end of a pen, the top of a pen cap, your long nails, or any other object to scratch inside your ear because it itches. And when it itches, then you break the skin. When you break the skin, you're opening the door to infection. So you'll get an outer ear infection. We call that swimmer's ear, but you don't necessarily have to be a swimmer to get swimmer's ear. Fluid. The fluid is in the middle ear. It is not coming from bath water, pool water, shower water. That fluid in the middle ear is coming from snot in your head, because there's an opening. Let's go back to the picture and you'll see where it says eustachian tube. The eustachian tube leads to the nose, the back of the nose. It's a hole in the back of the nose. So if you get real snotty during allergy season and there's enough mucus that collects, or you get a really bad cold, or you get COVID, you get a lot of mucus building up, it will collect around that opening where the eustachian tube is inside your skull in the back of your nose. When you lay down, I want you to imagine that ear rotating sideways. When you lay down, that fluid creeps up that eustachian tube and will get in the middle ear. If enough of it gets back there, your head is nice, warm, and dark, which is a great vacation place for bacteria to grow and mate and have more bacteria. And as it grows, then it starts to swell. That's where you can get a bulging eardrum, because there's so much fluid back there. It's kind of like a water balloon. You pump it up, pump it up, pump it up, pump it up, and it's got water in it, and you keep blowing, and it swells up. So there's so much pressure, boop, it ruptures. And when it ruptures, that fluid will come out. You will have an excruciating pain in your ear. You'll have excruciating pain while it's swelling. That's from a middle ear infection. So an outer ear infection is in front of the eardrum. A middle ear infection is behind the eardrum. That's when fluid is back there. Okay? Hopefully I made that clear as day. So just quickly, there's sensory neural hearing loss. Go back and look at the video and read it on your own. And then there's mixed hearing loss. All right. So the prevalence and demographics, mostly kids are going to get the conductive hearing loss problems, conductive loss issues, but it does not mean that adults cannot get conductive hearing loss issues. But the prevalence is more in a younger demographic. That is why, for the most part, this is a generalized statement. I'm a provider. I'm a licensed physician assistant. So the things that I'm telling you are studied and learned, and they're not just opinionated things. I'll let you know when it's just my opinion. But this is just a generalized statement. Kids usually get tubes, but grandma and grandpa end up getting hearing aids. That's because of the difference in the loss. That doesn't mean that kids cannot get hearing aids. That is not what I said. If that's what you're taking from this, you're wrong. All right. So kids get conductive hearing loss more because they get more middle ear infections. The reason why is most, especially little kids, 12 months, 2 years, 3 years, 4 years old, their heads are still developing. So their eustachian tubes, which I'm going to pop back to that screen, that where you can see this eustachian tube is angled down. Theirs usually is more flat. So instead of having an angle, theirs is more flat. Kids are more flat. So they don't drain as well. If they don't drain as well, and the other thing is they may have large adenoid tissue or swelling tissue in the back of the nose. If that happens, it blocks up the end of this eustachian tube and it traps fluid back there for kids. So that's why they end up having conductive hearing loss a little bit more than adults. Now, let me say this. I'm going to take the time to say this. If adults have a middle ear infection and it doesn't clear up after a while, like 3 months, 6 months, it is definitely worth you going to see your friendly ENT, because they may need to look in the back of your nose and see and make sure that there is not a cancer or a growth or a mass in the back of the nose that's blocking and trapping fluid, making you have conductive hearing loss. If that's the case, when you go to your audiologist, not to the audiologist, when you go to the otolaryngologist, they're going to slide a little camera through the nose and look back there at the end of the opening where the eustachian tube is to make sure that it is free and clear of any tumors, lump, bump, growth, mass, or something like that. So if you're an adult and you've had hearing loss for a long time, it feels muffled, it feels like something stuck in your ear, you need to go see your ear, nose, and throat doctor and let them slide a little camera back there and find out if there's fluid back there. Okay. So conductive hearing loss usually affects children, but it can affect adults. If there's unilateral, most of the time children have it on both sides. Adults will have it on one side. That's some sign that you're going to have to do that nasal exam to make sure that there's not a tumor or a growth. Causes of conductive hearing loss, common things are ear infections, significantly higher in children. Now, other causes, you can have a lot of thick wax, but I tell you, you got to have a lot of wax to have significant hearing loss. Now, when you look at this hearing test, where you see the blue, remember I taught you in the last section that blue or X's represents the left ear. All the time, universally, the O's and red represents the right ear. Even on hearing aids, you'll see a little blue dot or a little red dot. Blue dot, left ear. Red dot, right ear. Okay? So when you look at this test, you can tell, I can tell as an otolaryngology PA that the X's are down lower than the half square, blue half squares, because there's a separation between the blue half squares and the X's. That's how I know this is conductive hearing loss, because my pure air tone is way down here and it should be up here where those half squares are. Notice when you look at the right ear, the red and the half triangles are both together. They're also above the 20 line. So where 20 decibel is, you can tell this is a normal hearing test for the right ear, but it's not for the left ear. There's some severe hearing loss right here. So because there's such severe hearing loss, and you can see up here where the nerve is, the nerve looks fairly like mild hearing loss. Okay. But with the X's being so far away from where this is, once you put a tube in that ear, this can move up closer to where that is, and then the hearing improves. Okay. Let's look over here at this test. This is a tympanogram. A tympanogram is very important during conductive hearing loss. If you have a normal middle ear where those three bones are behind the eardrum, if you have a normal middle ear, you'll get this triangle, this pop-up mountain peak right here, right over the 0. If you have fluid in that middle ear, or you have a hole in that middle ear, or you have a hole in the eardrum, you're going to get a flat line. So if you have a hole in the eardrum, the way I can tell is there's a reading and a number that I would look at called a external canal volume. Let's go back real quickly. The external canal volume, that means there's a sealed off eardrum, a sealed off ear canal. So right at the front, a little machine goes there, seals that off, and it will measure that ear canal up to where the eardrum is. If there's a hole in there, that number is going to be greater than 1.5. If that number is less than 1.5, that external canal volume, then that lets me know there's fluid in there. Okay. If you're not tracking, we'll get to that later. You'll probably be able to see it later on. So the things that we should take from this slide is children are affected more with conductive hearing loss than adults. Doesn't mean that you can't be. Wax causes some decreased hearing, not really significant hearing loss, but it can change your hearing, make it more muffled. The tympanogram is very important because it checks the middle ear for us to let us know if it's a mountain peak, that's a type A tymp, it's normal. If it's flat, it's either got a hole or fluid back behind there. And then if there's negative pressure, the eardrum pulls backwards. So it kind of looks like when after Thanksgiving, all the women go in the kitchen and they start packing up the food. And as they pack up the food, then they put the saran wrap on there, stick it in the refrigerator. But when you come back 3 hours later to graze again, you'll notice that there's some condensation, and the tight saran wrap put on the bowl is kind of sinking in. That's kind of what an eardrum looks like when that happens. Okay. So now let's look at different testing. What you're seeing right now is someone getting a hearing test. Someone getting a hearing test. You'll notice there's a blue and a red side. Blue is left ear, red is right ear. So when you have conductive hearing loss, some of the symptoms are going to be things are muffled. It's not as loud as it was, the impact for your hearing. You will have a full feeling in your ear, like something stuffed in there, if there's fluid in the middle ear, or if there's something called a cholesteatoma. Cholesteatoma, we'll talk about that a little bit later. Or your voice sounds real loud to you. You almost sound like you're in a bucket. You sound like you're underwater, like it's in a tunnel. Those kind of symptoms are indicative of conductive hearing loss. Again, we show the diagnostic testing that we're looking at. On the diagnostic testing, you see we need hearing tests for the comprehension and understanding to give you a better diagnosis of what your problem is with your ears. So the audiogram, that checks for pure air. That's what the X's and O's do. Now on this test, looks like this person has some pretty significant hearing loss. And so there's some, I would say, moderate to severe hearing loss in their pure air tones. If you look at the X's and the half squares are a little bit higher. When the X's and O's are away from the half squares or half triangles on your audiogram, that indicates that there is some conductive hearing loss. If these are both down, then that's sensory neural hearing loss. We'll talk about that when we get to that. That's on a whole nother episode. So here is the test that I was talking about, the tympanogram, which is vital for indicating whether we have middle ear dysfunction. Middle ear dysfunction. With the top one, we have a normal. That's a type A, where there's the mountain peak. With the flat, you either have fluid in the middle ear, fluid behind that eardrum, or you have a hole in that eardrum. That depends on what the external canal volume is. And then when it's pulled backward, that's what this mountain peak in front of the zero is. That means there's negative pressure. So there's something going on with the eustachian tube. It's not doing what it should do, and it's not pressurizing the air. So you've got the audiogram, where she's sitting and doing the audiogram, and then you have the tympanogram, which seals off the ear canal to the eardrum and measures that volume. All righty. So to fix these problems, you have to usually do some medical or surgical intervention. Some of the medical intervention is going to be placing antibiotics. If you have an outer ear infection, drops will work. If you have a middle ear infection, drops will not work. Well, why is that, Miss Johnson? I don't want to take any oral antibiotics if I have a middle ear infection. I just want to take drops. If I just put drops in my ear, then it won't hurt. I would rather, and I don't have to swallow nothing. I don't have to, listen. If you have an ashy arm and you put saran wrap over your arm and then put the Vaseline on there, did you take away the ash? Thank you. No, it doesn't work. Because the eardrum, if the eardrum is closed, then you're not getting any medication into the area that needs to be taken care of. That's why if you have fluid in the middle ear, you have to have oral antibiotics. Now, if you have an outer ear infection, the drops on top of the skin, that's because it's a skin infection. So you could put the drops in there and that will heal that up. Now, if your ear is so swollen and it's swollen shut, just like this, it's swollen really tight, then you can't even get the drops in there. What happens is the drops sit right on the top, and so they don't do anything. Therefore, you need to come to your friendly ENT and let us push a little wick in there. It's a small little sponge called a wick. And you know that when a sponge, when it's dry, when you first buy them, they're flat. And then after you wet them, they swell up. So we put a little wick down in there. We squeeze it through that area. And once we squeeze it in there, then you can put drops on there and the medicine will go onto the sponge, which gets down to the area that needs to have the swelling go away. So when we give you the drops, the antibiotic drops with sometimes a steroid if you have a lot of swelling. So you may get something called Ciprodex, or you may get something called Neosporin polymyxin. Let me tell you something about that. Neosporin polymyxin is a great, cheap, inexpensive antibiotic that they want to give you. The problem is if they give that to you and you have a hole in your eardrum because of surgery, like your child, You can't use that because that is like an aminoglycoside type medicine and it can damage your hearing for good. So you don't use that. You have to use Ciprodex or ofloxacin. Ciprodex or ofloxacin. If you have a hole in your eardrum, you need Ciprodex or ofloxacin. If you don't have a hole in your eardrum, you just have a plain old infection, you can use a Neosporin polymyxin. The other thing, or quartersporin otic drop, those are fine. Now, if you have an infection to sulfa, the quartersporin or the Neosporin polymyxin are not good medicines because they have sulfur in them, and it can cause your ear to swell up and you get a rash and it itches, and then it gets a super infection on top of that. So if you're allergic to sulfur, you can't use that quartersporin or neomycin. You have to use the ofloxacin or Ciprodex. These are just some that's just some gee whiz information for you to keep with you so that you can understand what's going on with you. Now, other things that treatments, that's if you're using medications and we're helping for infections. But if you have to have surgical intervention to help with the eardrum because there's so much fluid back there. Now, your child may not have a ear infection per se where there is fever, chills, pain, or them pulling at the ear. They just constantly stick their finger in their ear and shake their head. Little kids usually shake their head and do things like that. If that's going on, then what you want to do is bring them to the audiologist, and then you also want them to see the otolaryngologist because they might have to put tubes in the ear. Okay, that's where you get what's called a myringotomy. And they will make an incision in the eardrum and suction the fluid out and put a tube in there. Okay. You could have something called otosclerosis. That's where, let's go back to the picture. I want you guys to understand this, and it's a lot to it, so I am taking a little bit longer than I usually do. But if these three little bones are fused together, what they're supposed to do is when they vibrate, they would shake, and that makes the other one shake because they touch. But if they're stiff because of otosclerosis or type of arthritis in that bone, then they don't work. The sound, you have conductive hearing loss because the sound is not vibrating like it should because those bones are not effectively moving like they should. So if they don't move and they're stiff from what's called otosclerosis or sclering together, that's bonding together, then when they don't move, you end up having conductive hearing loss. And they have to do surgery to do that. If they do the surgery, then you don't have to have a hearing aid. However, if you choose not to go through surgery, say this is an adult person, a senior adult person with multiple health issues, cardiac issues, lung issues, and all that, and we really can't put you to sleep under anesthesia to do a 2-hour procedure, then it's just easier to just put a hearing aid on you. Okay. We had a lot in this. This is the cholesteatoma that I was telling you about, how you can get cholesteatoma is an abnormal growth in the middle ear. That means behind the eardrum, and it can form at birth. It's rare, but it can form at birth. And typically it's because of chronic ear infections. So normally you're not born with an ear infection, but you could have fluid there. And then what'll happen is that thing starts to grow and grow and grow, and it'll rupture through the eardrum and cause a lot of leaking. If you have a small child with a lot of chronic leaking stuff out of their ear, they need to see an ENT doc. So those are some of the common symptoms. You can also get some dizziness with that, cholesteatoma, and that fullness in the ear and discharge coming out of the ear. Okay. Now, I wanted to make sure that you understood about the tubes and how they go in. So if you have someone that is talking to you about putting tubes in your child's ear or your grandchild's ear, and you're not really sure what's going on, and they talk to you and didn't show you the pictures, well, here I am. I'm going to give you the real nitty gritty. So the ear tube insertion is called a tympanostomy tube. Tympanostomy tube. They're very, very small. You cannot see them. They go into the eardrum and nobody knows that your child has it. So they go in to the eardrum. Your child is asleep for about 20 minutes. They make an incision in the eardrum, suction out the fluid with a little suction, and then they pop the tube right into that same little hole, and the tube sits in the eardrum anywhere from 12 months to 24 months. So from 1 to 2 years, that tube can sit in there. It keeps the middle ear dry, and it keeps the child from getting recurrent ear infections. They sleep better. They hear better. They respond better because there's no fluid in the middle ear. Those tubes will fall out. That tube will fall out within, like I said, 12 to 24 months. It falls into the ear canal and works its way out on its own. When it falls out, right behind it, within 3 days or so, that hole closes up. It heals up on its own. The eardrum just heals up on its own. Now, it is rare. About 1 to 2% of kids, the tube will fall out and the hole does not close. Oh my goodness. What does that mean, Ms. Johnson? Well, I'm so glad you asked me. When that falls out, if it's just a pinhole size, a little teeny hole, we do nothing because it's really not going to affect the hearing, and it acts in a good way for the child. If the tube falls out and the hole is still big or large, we get a hearing test to see if there's conductive hearing loss. Then the child has to be brought back in so that they can put a patch over that hole. And it's as simple as that. So the ear tubes fall out in 12 to 24 months. After 24 months, we start talking about taking them out if they do not fall out on their own. So we usually let them within anywhere from 2 years to 2.5 years, we start talking about taking those tubes out. Because then the tube will start acting like a foreign body, and you'll get a constant runny, snotty discharge out of there, and you're constantly putting them on antibiotics until the tube falls out. After a while, you just go ahead and take them. We just go ahead and take those out, okay? And patch that hole up from where we take them out. Now, we have come to the conclusion. I am so sorry that I kept you guys a little longer than you normally get kept, but it was just a lot of gee whiz information that I wanted you to have. For the conclusion, I want you to understand that diagnosing conductive hearing loss is crucial for effective management. We have to know whether we're treating one of the three or a mixture of both. Okay, we have to know because it helps us to give you better information for you to make a better informed or more informed decision. This is what this show is all about, arming you to be educated, to understand what's going on with your body, and to be able to sit down and have a good conversation. Providers may not be able to give you all the information, and that's why I'm taking 45 minutes to talk about conductive hearing loss. There's no way you're going to get a 45-minute visit with your doctor. You bet you might get a good 25 minutes out of there. All right, but it's not our fault. It's just the way it is. So treatment and support options, that varies on the hearing type and the type of person it is and what's going on. Your quality of life is improved with the right interventions. All righty. I'm going to let you go, but I'm going to be so excited to see you all again next week. Hey, keep praying for the station, for the channel, and for the podcast, because we are growing, glowing, and doing well. And I want to continue to be able to give you some great information. We're going to be mixing in some interviews. You're growing with me, and I thank you for being patient and growing with me as I learn how to do everything. I'm looking for a production manager to come and help me with doing some of the things that I have to click on. Until next week, because next week we're going to be talking about another great show, and that's going to be on sensory neural hearing loss. Probably be taking about this much time again. All right. Until next week, see you then. Hopefully, your horizons have been enlightening.